All right, we're going to switch gears, talking about fifth metatarsal fractures. David Pedowitz, dear friend, will be leading this session. Dave, it's all yours.
Good morning, everybody. Thank you. Sorry for the technical difficulties. We're going to talk about fifth metatarsal fractures this morning. And first, I'd like to introduce my panel. I had a slide, but it doesn't look like it's going to come up. We have Jean Brilhault from Tours, France. We have Derek Donegan from the Trauma Service at the University of Pennsylvania in Philadelphia. And we have Shay Tenenbaum from Sheba Medical Center outside of Tel Aviv, Israel. And myself, I'm David Pedowitz at Rothman Orthopedics at Jefferson. And so I hope you find this educational as well as entertaining. So these are my disclosures. I want to start by thanking Selene. Selene has been a good friend of mine for a long time. We did residency together, and he is currently one of my partners. We've worked together designing, publishing, research, as well as numerous international trips, and it's just a pleasure to work with such a motivated and high-functioning individual, and I'm really excited to be a part of this endeavor. So let's start with this. Fix it, yes or no? Derek. This is a bunion neck correction that went wrong and shows up in my office. You go back in and fix it, or this will be fine?
I think I'll fix that.
Shy.
Was it done minimally invasive or?
It was, yes.
Minimally invasive?
Yep.
Then I wouldn't touch it.
Okay, what about you, Jean?
Me neither.
Okay. So it's crazy how sometimes things can heal without any intervention, right? So this is a what looks like a diaphyseal stress fracture. Fix it, Derek?
Depends on the patient.
Okay, Shy?
Same answer.
All right. Jean?
Same here.
All right, fine. I fixed it. All right. So in general, fix it, Derek?
Again, depends, but probably let this one heal.
Okay. Shy?
Most probably not.
And what about you, Jean?
I
Same.
said most probably not.
Yes.
Okay.
No.
Yeah, healed very nicely non-surgically. Okay, this is I'm doing an ankle fusion. The patient hasn't had an X-ray for 2 months. I'm in the surgery, and I'm just getting an X-ray of her foot, and she has this. And I have the X-rays in the operating room of the foot from when I last saw her 2 months ago, and she doesn't have a fifth metatarsal fracture. So I'm in the operating room, and there's this. Fix it?
No. Realign the ankle through fusion.
Yeah, so I'm doing the fusion. She was in varus. I've corrected the varus now. Leave it or fix it?
Leave it.
Derek?
I'd probably leave it too.
What about you, Shay?
I would probably leave it.
I fixed it. Because I was there. I was just like, I just don't want this to be a problem. And then how about this? This is a runner who has a fifth metatarsal neck fracture that's like displaced plantar. You guys do anything with that?
I'd probably leave it.
What's the mechanism of the injury?
Running. It almost looks like a surgical cut, but it's not.
David,
The long story short, I let him walk on it, and it actually displaced up into like physiologic position. All right, so there's a lot to say about fifth metatarsal fractures. So let's start. We're going to start with a discussion of Jones fractures, and then we'll go through cases, and cases. So as we all know, there's zone 1 fractures, there's zone 2 fractures, and there's zone 3 fractures, which are really important to be able to understand the difference, right? And the frequency is as we just said. And the Jones fracture is really what we're most concerned about, exiting at the 4-5 articulation. And historically, right, this is related to blood supply. As we have fractures distal to the tuberosity. And as you can see here, the blood supply comes in a little bit of an interesting direction. It's funny how this is the one metatarsal that just seems to have trouble healing. And patients present with that acute like pop, almost like when they have almost like when they have an Achilles tendon tear. It's important to assess the chronicity right? As we see here, where you have like almost an obliteration of the intermedullary canal as opposed to just an isolated acute fracture. And Dr. Torg, actually, who's here in Philadelphia, or was here in Philadelphia, was the one who initially classified this into type 1, type 2, and type 3 fractures based on healing potential. In general, he thought that type 1 should be treated non-operatively, type 2 should be treated with surgery depending on activity level, and type 3 should get surgery. But a more recent classification looked at whether or not it was a metaphyseal fracture or a metadiaphyseal fracture, suggesting that the metadiaphyseal fractures would benefit more from surgery. And there is this old article. So my father, may he rest in peace, was an orthopedic foot and ankle surgeon. He used to always quote this article from from the 1980s. This guy named Grantham, who had 36 non-athletes, who did 5-year follow-up of non-operatively treated Jones fractures, and he allowed all of them to weight bear for 2 to 4 weeks, and he had no non-unions. It's a terribly done study, and somehow it was published in our journal. But here's the problem, right? And this is my son playing soccer, but 18 to 25-year-old athletes, and non-athletes even, right? They're not willing to tolerate 8 weeks of non-weight bearing, 3 months of like a return to play attempt, a 26% non-union rate, pain and workup, then surgery, 3 more months out of playing, and then you've like ruined half a year. Or at least that's how like the athletic or the adolescent mind sort of thinks about it. So there obviously are surgical solutions, both plates and screws and all this other kind of stuff. And I'm just going to do a few slides of just some literature review, and then we'll get into some cases. If we look at a systematic review, just is operative intervention justified? 6 studies, non-op had a higher non-union and a prolonged healing time, longer time to return to sports. If we look fixation versus casting, a randomized controlled study from 2005, 2-year follow-up, which is pretty good, 44% non-op failure. Return to play was 8 weeks, it's pretty good, but a non-op return to play was 15 weeks. If we look to return to play in NFL players, okay, 8.7 week return to play, mostly wide receivers, linebackers, and tight ends. If we look return to play in the NBA, okay, this is 26 athletes, return to play was 9.8 weeks. If we look at operative treatment in the NBA, this is only 10 athletes from Marty O'Malley, but also return to play 9.8 weeks. If you add bone grafting for refractures, return to play seems to be a little bit longer. There is some thoughts. There are some thoughts about bone marrow aspirate concentrate. There is no data on it. There is an ongoing prospective randomized study that is looking into this. It is an added cost. This is the one study that I talk to everybody about, residents, patients. This is looking at Jones fractures in college football players who are being drafted into the National Football League, right? So they're at the NFL Combine, and anyone who's had surgery or on their 5th metatarsal gets a CT scan. Well, if you look at that, there's 50% incomplete healing. So obviously these patients are playing American football at a very high level. They are not having pain, but at the Combine, they get a CT scan, 50% incomplete healing. So just something to sort of chew on. All right, let's start with our first case. So this is a 21-year-old lacrosse player. He feels a pop in the right foot when he steps on a ball while running. Derek, what are your thoughts?
Yeah, I mean, I think it depends on where he is in the season. Obviously, you have that proximal 5th metatarsal fracture. I think you just mentioned, getting this person back to sport, if, depending where he is on season, what his plans are going forward. I think that's the type of discussion you have with this individual about managing him operative versus non-operative.
The questions I have for you guys is, what is the optimal treatment? I think in general, and tell me if you disagree, Derek, most U.S. competitive athletes, they get surgery for this, even though it's a non-displaced fracture.
100%. I think that the conversation definitely gets driven that way.
Shay, is that different in Israel?
Actually, no. I think we're going with the same direction.
What about in Europe, John?
Same here. Same here.
Yeah. So, oh, I'm sorry. Let's keep going. Yeah. And then the next question would be, do you think biologics have a role? So like, I've always had some thoughts about, you know, Bob Anderson and the Charlotte group were the ones who sort of pioneered this idea of, you know, bone marrow aspirate or some biologic that you inject in or around the fracture site. And my initial thought was like, these are like the healthiest people in the world that we operate on. Like, why do they need any biologic augmentation? Does anyone have any thoughts about that?
Yeah, just to put my overall fracture hat on, Dave, I think, you know, I know it's a questionable area from a biology perspective, but you know, other long bones where you treat with intramedullary devices, you know, the manipulation of the intramedullary canal, either with a reamer or a drill bit, which acts very similarly, stimulates the, you know, bony healing inside. So, you know, I agree with you, kind of these younger, healthy people, you know, I tend not to augment this, but that's because I think we're stimulating the bone intramedullary when we manipulate it to fix it.
Okay, I think that's a very reasonable thought process. Is there any role for a bone stimulator? John, do you have any experience with bone stimulator in this setting? How about you, Shay?
Well, I have some small experience, especially with patients that were a bit reluctant to go and have surgery. So to be completely honest, I am not sure if it's the stimulator that did anything or just, you know, time passing and the fracture healed naturally. But yeah, it makes everybody feel good that we're still doing something. So I tend to recommend on patients who don't want to have surgery that to try bone stimulation.
Yeah, everyone likes it except the U.S. insurance companies. They don't like it very much. So I'll show you an interesting case. So this is a 22-year-old male non-smoker. He had a tibia fracture 1 year ago in the Ivory Coast, fixed with this like wire. Okay, and he's a student. He has pain with weight bearing, and he doesn't want surgery. So I was like, all right, well then you can try a bone stimulator, and it worked. So like, I don't know if that was just time also, but like sometimes I've seen bone stimulators do things that I don't expect them to do. That's not my preferred method of treatment for a Jones fracture, but I don't know. Sometimes things do work, and I agree with you. Sometimes you're just sort of giving them a device and they think it's working, so it's probably working, but who knows? So this is sort of my setup. I was just wondering what everyone else's setup is for this. Like I do use either a regular C-arm or a mini C-arm. Do you guys use mini C-arm or do you use regular C-arm?
Mini C-arm on the feet.
Mini.
Regular one on the ankle.
What about you, Shay?
I almost always use a mini C-arm.
And do you put lead on the patient?
No.
No, I don't either. Derek, do you wear lead when you do these?
I wear lead all the time. Yes.
Yeah, I do wear
I
lead.
I use a regular C-arm though. I don't use a mini C-arm just because it's functionally easier for me.
Even when, Jean, do you wear lead when you do this or no?
Not if mini C-arm. Yes, if regular C-arm.
Okay, so I used to be like that. However, I mean, I was always thinking that the importance is the cumulative dose, right? Like while the mini C-arm, if I'm taking 2 shots, it's really, I don't need any lead because it's so little radiation, almost just like standing outside, you know, during the day. But if I'm taking many shots and I have many cases during that day, that perhaps it's worthwhile to wear lead. So that was sort of
totally, Dave. And then there's cumulative over your career as well. So you gotta keep
there's cumulative over your career as well. Exactly. Do you wear lead glasses?
I do. Yeah.
Yeah. So those are lead glasses that I'm wearing there. The only problem is my nose hurts at the end of the day.
Yeah, they're all too heavy. That's a different. That's an off-topic conversation. We could probably design something.
Right. So this is just sort of my technique. It's not very unique. As you know, it's just a straight wire and a curved bone. It goes in pretty good. It's not particularly complicated, and it's easy and predictable. How do you determine the size of the screw, Derek?
I try to get at least a 5.5 millimeter diameter screw in. I think the literature supports kind of being on the bigger side of that. Obviously, if they have a very capacious canal, then go bigger. But I tend to be at least 5.5.
No, but how do you determine that intraoperatively, that that's appropriate or that wouldn't be too big or that you need something bigger?
Oh, it's kind of a gestalt, I guess. I don't have any really good way of measuring it. I think there are some tools you can use to measure it, but I don't have any great pearls.
Shay, what do you do anything special?
No, just a guesstimation.
I sort of I hold the screw over on top of the foot and X-ray and sort of look like if there's a canal fit or something like that. I don't know if that's particularly accurate. It's probably as accurate as an applause meter, but it's at least something that makes me feel good.
I mean, in theory, you could do it like any other thing. You could quote unquote ream up using drill bits to get appropriate chatter and use that appropriate diameter screw.
Yeah, but either way, it works well. This is an example of this app running treadmill at about 6 and 8 weeks. So, what's your post-op protocol for this? Do you let them walk? Do you put them in a cast? Do you make them non-weight bearing in a boot, John? Boot? Weight bearing or non-weight bearing?
Weight bearing, if not painful.
What about you, Shay?
So my first go-to is actually a cast for at least the 2 first weeks, and I don't allow any weight bearing for at least a month. Maybe I'm over conservative with that issue, but that's the way I do it.
What do you think, Derek?
I put everybody in a splint for 2 weeks just from a soft tissue perspective. I just don't trust people. And then at 2 weeks, if everything looks good, I let them put them in a boot. Weight bearing is tolerated. And start
weight bearing is tolerated. Yeah, I mean, I haven't done the weight bearing as tolerated, but if you can put people in a boot and sometimes get a union, if you have the screw in there, why can't people be weight bearing as tolerated? Here's another case, 70-year-old female breast cancer survivor. She's on bisphosphonate therapy. She twisted her foot at home and she has a trip to Machu Picchu in 3 months. Shay, are you fixing this? Or are you giving her just some encouragement, making her non-weight bearing, making her weight bearing? So she's obviously an active 70-year-old, but she's on bisphosphonate therapy already. This is probably, almost like an osteoporotic fracture. What are your thoughts about a case like this?
I would not go with surgery. That would not be my first offer. I would treat her conservatively, 6 weeks, non-weight bearing. Obviously discussing with her because it's extremely inconvenient not to put any weight for 6 weeks, but I would go conservative.
John?
I would give it a chance to conservative treatment. Let's say discussing with the patient for at least 3 to 4 weeks. If it doesn't seem to heal, then I go in.
Derek, what are your thoughts on this one?
Yeah, I don't know. I think you have to have a conversation with her. I think, take the trip from Machu Picchu out of the picture. I agree with what everyone else just said, but I think that would drive my conversation with this individual. I mean, who knows? That might be a big bucket list thing for them, and it can't, that's might be the thing that drives us. If that's the case, then I would consider fixing it.
Yeah, she did fine non-surgically, but I did make her non-weight bearing. When I make people non-weight bearing, I made her non-weight bearing because I felt like she's super active. She wants a good outcome, and she has a bunch of other reasons to not heal. So I made her non-weight bearing, but I do tell them that, if you need to put your foot down or your heel down to go to the bathroom or to get up a step or to balance, it's fine. I just don't want you walking around. You don't have any problem with that, do you?
For how long did you keep her non-weight bearing?
6 weeks.
Okay.
Yeah.
Yeah, it's interesting, Dave. I think that's fine. I just presume everybody's going to walk on these things. I mean, I don't tend to trust many people. You know, if we do these massive acetate reconstructions, they come and walk in on them sometimes. You're just kind of like, what's the deal, you know? So I think it's hard to really know if people are staying off it or not.
Yeah, I think you're probably right. Okay, this is a 19-year-old freshman Division I diver. She has a Jones fracture over the summer fixed in Kansas City, and now she's training for the season and she feels a crack. So she's already had surgery before, and she shows up with this.
Yikes.
Shy?
Do you have by chance the immediate post-op X-rays? Or
They look
I'm actually asking if the screw was in this position to begin with.
It was.
Then obviously after discussing this with the patient, I would go for taking the screw out and putting another one. Hopefully, I'll succeed a little better with the position.
Is there a role for like non-surgical management?
I would be very worried leaving the screw like this in a professional athlete. I mean,
and what about do you think we need to open the fracture site here, or does this just need like the correct surgery done at this point?
Okay, so I would try first doing it closed, just changing the screw, rimming from the inside and just changing the screw to another position. But I would say that I would not hesitate to open. I mean, if I need to open to get a good, surgical result, I wouldn't hesitate.
Does anyone have any different feelings about like biologics in this setting? So essentially a refracture?
Yeah, I mean, I think, you have to try to understand why this thing didn't heal, right? And so is it a stability issue? Is it a biology issue? Is it a combination of both? And, we could all probably agree that maybe the first surgery wasn't performed correctly. So maybe this is just a stability issue, and, getting the appropriate mechanical environment for this to heal would be just fine.
Okay, so here's what I did. So I went in there, step one, I removed the screw. Okay, great. Okay, then I get a K-wire in. It looks pretty reasonable. I think we can all agree that that doesn't look so bad. I did inject some bone marrow aspirate concentrate from the iliac crest. I just figured like, hey, why not? This is a competitive athlete. They already had like an additional problem because there were x-rays where the patient had healed, right? So I don't know. So I just figured like, hey, that's not such a bad thing to do. Okay, so I go to put in the screw and it keeps wanting to go in that old direction. And because the foot's in the way, I can't adduct my hand enough to get it to like go around. You guys have any suggestions? Like I'm literally trying like so many times. It will only go in that one spot.
But you had a K-wire in, right?
Right, but this is not a cannulated screw.
Yes, that's what I mean. So
Yeah.
maybe it's an opportunity to use a cannulated screw.
My only problem with that is she already failed a rigid screw. And I get it, that rigid screw, that solid screw wasn't in the right position, but I didn't want to use a cannulated screw because that does have a higher failure rate.
Yeah, I mean, you could use something mechanical to block the trajectory of your screw like you could use a 2.0 K-wire or even like a mini frag screw, like a cortical replacement screw
Okay,
to redirect your screw trajectory.
so I put that like K-wire right there. It's kind of like from dorsal to plantar a little bit. And that didn't really work. So I had to put another K-wire, actually, a second one in to kind of like make it so that it couldn't possibly go in that hole. And then finally it went in. And it eventually, what's that?
That's the polar screw concept that we use in reaming.
Right. Yeah. So it healed on eventually, like an hour, after an hour and a half of what I thought was going to be like a 15-minute procedure. And no one really knows like the struggle that you go through in the operating room, unfortunately. But it's crazy, right? Because this person has outside surgery and no pain. So I guess even bad surgery sometimes works out, right? There's a bunch of these like situations, you never know. I didn't do this, but like that's terribly placed. So, all right, case number 3. This is a 42-year-old male, head-on collision into a tree, wearing a seatbelt. The airbags are deployed. There's an unclear mechanism of a left ankle injury. There's no open wounds. He has ecchymosis of the ankle and the foot. And so here are his x-rays. He has a zone 2 fifth metatarsal fracture. He does, based on a CT, he has a medial dome and posterior talus fracture, but it's operative based on the CT. So really what I want to know is, what do you do with the fifth metatarsal? Do you not operate on it because he's going to be non-weight bearing for quite a bit of time because he has a talus fracture that you're operating on? Or since you're going to the operating room anyway, are you going to operate on it? What do you guys think?
I would probably not operate on it, but I mean, I think you can make the argument either way.
Okay. Any other thoughts, guys?
It's non-displaced.
It's non-displaced.
Yes, it was some sort of high velocity. So
yes,
basically it's stable. So
yeah, you're probably right.
Weight bearing, because it's non-displaced, I think it will heal. So I will treat it non-operatively.
I was more aggressive with it, and I didn't think that a screw would work because it had these 2 fracture lines. I thought maybe that I would like blow it apart. So I just put a plate on it, and maybe that was the wrong decision. It ended up healing uneventfully. But I just felt like I'm there in the operating room anyway, and maybe that was too aggressive. I don't know. It worked out okay. But that's what I ended up doing. Here's our next case number 4. All right. 28-year-old male landscaper, smokes a pack a day. He's at work and his foot is hit by this soil compactor. You've seen these things, they sort of like push the ground down. It goes onto his foot, and he's not wearing maybe he is wearing a like a steel-toed boot, but it's not steel foot. It's just the toe. It's the tips of the toes that it's covering. So here's his injuries. So in case you can't totally see, he's got 4th and 5th metatarsal fractures. He has a calcaneus and a cuboid fracture and a navicular fracture. So basically a pretty bad crush injury to his foot. But this isn't really what I'm going to ask you about. He has surgery somewhere else, and he comes back with this, and he presents with pain. Okay? He wants his hardware out. He's not back to work. He's hypersensitive over his entire foot, and he's on his maximal dose. He's on the maximal dose of gabapentin. Shay, what are your thoughts? I didn't do this.
So for now, we actually don't have a diagnosis. We're not sure that. I mean, I would guess that it's not the hardware that's causing him the problem. So going in and taking out the hardware, I kind of failed to see how it's going to help the patients. And actually, if it's some kind of a pain syndrome going on, then I would not want to operate on that particular patient. So do you have, by chance, a CT scan? Maybe there's a non-union underneath all that metal work?
It doesn't look that way. I did have a CT scan. It doesn't look that way, but at the same time, it's so hard to see. There's so much metal there.
I'm afraid that this is one of the patients that I cannot help with surgery.
What are your thoughts?
Now.
I will try to make sure to rule out an infection, an ongoing infection. Other than that, it's medical. It's not surgical.
Derek?
Yeah, I would agree. I mean, I think this type of patient has to make your spidey sense go up a little bit and see if you really can make him better with surgery and be very specific about what you're doing surgically. I would agree. I think this sounds more medical. If there's not an infection, if there's an infection, then obviously getting this hardware out is going to be helpful for this person.
Well, let's just say he didn't have a hypersensitive foot and didn't have like this complex regional pain syndrome type picture. Is taking out the hardware reasonable then, if he just has some soreness?
I think so. I mean, I think, if you can narrow in the fact that the pain's somewhat related to the hardware, I think there's a physical and a psychological component to hardware, that people tend to get better once they start perseverating on the fact they have hardware in their body when you take it out.
And there also is this workers' compensation type of claims and cases in the United States also have like a little bit of a game and a sort of a feel to them where the patient wants something done. They're maybe or maybe not interested in going back to work, but the company and the insurance company, they want the case done. So if there's something that can be done, they just want it to be done. And if it works, great. And if it doesn't, that's fine too. So there is almost like a pressure to just say like, hey, his hardware might be bothering him. He's maxed out his treatment with his physiatrist or pain management specialist. Can you just take out the hardware? All right, what are your thoughts about taking out hardware in patients who almost have this hypersensitive foot? Because I feel like I can make them worse, but at the same time, their hardware might be bothering them.
Yeah, I try to stay away from that, to be honest with you, Dave. I think you're just going to make that the hypersensitivity, you could make that go down a path where you can't come back from it.
Yeah, I agree. I didn't end up doing anything for this patient. I just had them continue to see pain management. And especially since this is not like a straightforward hardware removal. This is not like a single screw you can just remove, right? So is there any role for vitamin C? I'm not sure that there is. Let's just keep going. All right, so speaking of multiple and comminuted fractures, when do you fix them? And sort of what are your general rules? Here's 3 separate scenarios. This first one is a 26-year-old physician with controlled insulin-dependent diabetes. He also has an ipsilateral second metacarpal fracture that's displaced that's going to have surgery. Don?
I mean, the parabola seems okay. I would tend to treat him conservatively.
How about you, Shay? Isn't the lateral foot unstable? Like all 3 metatarsal fractures? Isn't the lateral foot like a little unstable with all 3 metatarsals like comminuted?
It is. I mean, I'm really tempted to actually fix this. Get a bit more of an alignment, maybe just fixation with K wires, just to get the foot more aligned. Especially because if he's gonna have some pain, let's say 6 months out of the injury, I would, to a certain extent, kind of regret I didn't fix it at the first opportunity, because now it's kind of an easy surgery, which won't be once the fractures are going to heal. So
yeah, I also feel like more. You can also like So I fixed it. I also feel like you can also probably weight bear them in that. And he was going to have difficulty weight bearing due to his hand, like non-weight bear, like crutch use. Derek, what are your thoughts about the second one? 22-year-old healthy skateboarder, 100% displaced second metatarsal fracture with a non-displaced, I'm sorry, third and non-displaced second.
Yeah, I'd probably treat that conservatively. I mean, I think you could make the argument to fix it. I think when, his medial and lateral kind of constraints are there, so his foot integrity should be fine. That deformity should heal and be okay.
Yeah, it healed great. And what about this one, Jean? This is a 60-year-old female triathlete. It's like super active. So in the office, she doesn't want to hear anything about non-surgery, but like you can still do non-surgery. I'm just saying she doesn't want to hear about it. And if you're having trouble seeing on your screen, you can drag the presentation and make it larger, actually. I don't know if you did that. What are your thoughts? Fix it, don't fix it. She wants surgery.
She got surgery if she wants it.
There you go. Yeah, exactly. So, all right. Next case, we have a 26-year-old male acrobat, works for Cirque du Soleil. He falls off a unicycle, okay, and gets this fracture. He continues to perform. Do you ever fix these? Shay?
No.
John?
Nope.
Derek?
Honestly, I do. And some people, really active people, I mean, I think, they want to get back to their activities. I think you can make a reasonable argument to fix.
So he doesn't want, he just wants to keep performing. So he ends up just doing whatever he's going to do. I give him a carbon fiber plate. He doesn't have surgery. And then 1 year later, he falls again. Okay. He went from that to this. So now he's got like a healed dancer's fracture and a Jones fracture in a professional athlete, essentially a professional athlete, right? Someone who's highly paid to do something pretty physical. So the question is like, do you fix it at all? Can a screw fit in there? Do you create a new stress riser by fixing it? Like, do you just leave it like it is and he's healthy and he'll do fine, just like he healed the other one? There's probably not really much of a canal. I don't know.
I would give biology a chance because he didn't want surgery at the first time. And because it healed already, although it's a totally different species, I agree. So I would tend to treat him non-operatively. And if then it failed, then it will make a case to go for surgery.
I think you're right. So I didn't see him in his last file up, which was in Las Vegas, but he ended up healing non-surgically. All right, so this is a 63-year-old male, avid golfer. 3 days ago, he twisted his foot in a sand trap on vacation. Okay. He says he also has had a lot of lateral foot pain for the last 6 months. And so now he has this. Okay. So he's got this he's got this fourth non-displaced metatarsal fracture. And he's got this non-union of the fifth. He's painful over the, over those fractures. He has a varus hindfoot. Shay.
I think we need to treat both pathologies, or maybe it's just one pathology. It's the alignment with the non-union. I mean, I think that if you're gonna just address the fifth metatarsal fracture, it's gonna fade over time with this kind of malalignment or cavus foot. So fix both.
And how are you fixing the malalignment?
With a calcosteotomy, most probably.
Okay, and what calcosteotomy are you using?
So now I do them minimally invasive. and I'll push, and I'll push the heel laterally or medially, depending on the case.
But you're not making a wedge.
No, it's a slide. It's a slide actually. But if you use the burr of the minimal invasive, a bigger one, so you can kind of create a wedge.
John, do you do that also, sort of like slide with like a bit of a wedge in an MIS fashion?
Yeah, I do the medial release first in order to get the vascular bundle out of the stress rise that you would induce, shifting the heel laterally, and then I go percutaneously and shift and rotate as much as possible to realign the heel and put 2 screws in.
So I did do that, just like you said. I also, like, sometimes when I do that calc osteotomy, I allow it to shift up a little bit because it almost like is like a little bit of a gastroc lengthening. Do you know what I mean? I have not ever seen tarsal tunnel syndrome from a lateralizing calcaneal osteotomy. You've seen it twice?
I had 2.
Okay.
And you don't want to have them.
No, you definitely don't.
It's been published, though.
Yeah, no, it definitely has been. I just haven't seen it. So yeah. All right. So I think this is the last case. So this is a 33-year-old prior bunion surgery, Jones fracture, rock climbing 1 year ago, rock climbing again, falls a few feet, lateral foot pain. Obviously, this was a failure of a cannulated screw. So the question is biologics. Does this need biologics? That's really what I want to know. Derek?
I would say yes.
All right, I agree with you. All right, last case, Selene, I'm going to be real quick. All right, so we did a revision ORIF with BMAC. I didn't take anything down. This is an interesting case. I have in competitive athletes who want their screws out, I'll take them out and then I'll fill the canal with bone marrow aspirate mixed with demineralized bone matrix. I've found that to work really nicely. I don't know if it makes any difference, but I've done that with competitive athletes. But this is the last one. 18-year-old university striker. Last game of the season, he's slide tackled. He has a contract with Major League Soccer already. This is the fracture he has. Is there any role for fixing it?
Yes, fix it.
Would you consider doing something like that?
I don't know.
No, it's terrible. You can criticize it. I didn't do it.
Maybe not the first choice, but
maybe not the first choice. So this is what we ended up doing. And you know, my final slide is this: is like, look, you can have like really bad stuff happen. This is one of our baseball players who had this injury, which is an open dislocation of his ankle. And this is him. This was treated non-surgically, just in a cast. We just closed the wound. This is him 3 months later, and he's still playing professional baseball. So you are right. Like I like hearing a lot of the commentary, which has essentially been, you know, surgery is indicated when it's indicated, but sometimes it's not always indicated. So I appreciate everyone's thoughts and chiming in on these interesting cases, and I hope it was educational for the audience. Thanks.
Yeah, thank you, everybody. That was awesome. I appreciate it. Everybody who's viewing, you can log out of this one and click the next session, and we'll see you over on the next session.